So our next speaker is Dr. Angela Mweempwa. Did I get that right? Angela is a medical oncologist from the Auckland Hospital in New Zealand. She's at the Harbour Cancer and Wellness Centre with expertise in gastrointestinal tract cancers and primary brain tumours. She also works in the Auckland City Hospital. She completed her medical oncology specialisation in Auckland and became a Fellow of the Royal Australasian College of Physicians in 2019. She subsequently accepted a clinical research fellowship at the Auckland Cancer Trials Centre, focusing on early phase trials. So Angela's going to speak with us today about new horizons in glioma care and clinical trials. Please welcome Angela.
Thank you very much for your kind introduction, and thanks for the invitation to speak. So I will take you through the topic, New Horizons in Glioma Care and Clinical Trials. I will help you understand what glioma is, go over what makes glioma trials different, cover the progress made so far in brain cancer research and how we can shape the future of clinical trials. So what is glioma? This is a primary brain tumor. It starts in the brain in the cells called glia, and it tends to remain confined to the brain, but sometimes it can spread to the coverings of the brain and spinal cord called meninges, and at times it can spread to the spinal cord as well, although this is not common. How do we classify glioma? This is based on how it looks under the microscope and also based on the molecular features present in the tumor tissue. The first test we do is IDH. So IDH is a genetic alteration in the brain tumor cells. If it's absent, the tumor type is called glioblastoma. And if it's present, there's an additional test we do called 1p19q. And when this is present, we call the tumor oligodendroglioma. When 1p19q is absent, we call the tumor type astrocytoma. There is a lot of additional testing required to try and grade the tumor, but I'm not going to go into that today. These are the standard treatments we use in glioma. Surgery, the goal is always maximal safe resection, but this is not always possible because of the important structures we have in the brain, and so sometimes only a biopsy is carried out. Radiotherapy and chemotherapy are also used in different types of gliomas, and I've listed only 2 chemotherapy drugs there, and that is because we do not have a lot of options to choose from. And this is why we carry out clinical trials. So the work starts in the lab where scientists identify potential new treatments, and these treatments then get tested in a first in-human trial, a phase 1 trial, and the goal of this trial is safety and dosing. This then progresses to a phase 2 trial, which is again to confirm the safety of the new drug and to identify the right dose. The work then progresses to a phase 3 trial where we're meant to confirm that this drug works and that it's better than the current standard of care or better than placebo, just depending on the comparator arm used. But what makes brain cancer research unique? Brain cancers are rare compared to other tumor types. It is harder to design clinical trials with the right comparator because we have a small pool of patients with a specific tumor type. Majority of the trials are early phase. They do not progress to phase 3 trials. The majority of the trials are single center, and we need more biomarkers. And then when it comes to the tumor tissue, there is what we call tumor heterogeneity. If you do a biopsy at different locations of the same tumor, it can look different. If you do a biopsy at different time points, the tumor cells and the molecular changes may be different. So what is a biomarker? This is a test we can do to aid with diagnosis, aid with the selection of patients, and it also aids with prognosis. It essentially just helps us choose the right patients for a particular treatment. An IDH is one such biomarker, or isocitrate dehydrogenase. We saw earlier how we use it for classification of glioma. When there is an IDH mutation, it leads to excess production of 2-HG. This affects cellular function. This suppresses the immune environment in the tumor cells, and it also causes epigenetic dysregulation in the tumor cells. So drugs have been developed to inhibit IDH, and vorasidenib is one of these drugs. It is specifically designed to cross the blood-brain barrier, and it has been shown to reduce the level of 2-HG by 90% in early phase trials. And by doing so, there is an increase in the immune cells, in the tumor microenvironment. It leads to an improvement in the cellular and epigenetic function as well. Vorasidenib was tested in the Indigo trial for low-grade glioma. These were patients with grade 2 astrocytoma or oligodendroglioma, and they all had IDH mutations. 331 patients were randomized, so assigned either to the treatment or to placebo. And this was a very positive trial. It led to a 65% reduction in the risk of disease progression or death. It reduced the risk of the need to receiving the next treatment, such as surgery, radiation, or chemotherapy. And it also reduced the seizure rate when patients were given vorasidenib by 64%. With regards to safety, vorasidenib was well tolerated. Only about 3% of patients had to stop treatment due to side effects. And when it comes to quality of life, health-related quality of life and neurocognition was preserved. Other trials have been opened since using the combination of vorasidenib with other drugs such as temozolomide and immunotherapy. And these studies are open in the US and Europe. So how else can we face the challenges of carrying out research in glioma? Through COGNO, which is a cooperative trial group for neuro-oncology, and it consists of health professionals, researchers, and consumers, all working together to improve health outcomes for patients living with brain tumors. And to highlight this, I've listed just some of the trials that have been completed by COGNO. These are multi-center trials, and some of them have been international trials, and these studies are now in follow-up. LUMOS-2 is another COGNO-led study, and this is for patients with low-grade and anaplastic glioma. And patients undergo molecular testing to try and identify the right treatment for them. And GBM Agile is a trial platform, an adaptive trial platform that also allows the use of one protocol to test different drugs and drug combinations for patients with glioblastoma. And as new information becomes available, new cohorts are opened, when treatments are futile or if recruitment is completed to a cohort, those cohorts are closed. So this is an efficient way of running trials because you don't have to write a new protocol every time there's new information about a new drug. And we also use targeted therapies. So these are treatments that are used to inhibit a specific mutation. So BRAF-V600E and NTRK mutations are quite rare in glioma, but when found, they are highly targetable. And the treatments for these mutations are available through the MOST program in Australia. A recent development is the FDA accelerated approval for dordaviprone, and this is an inhibitor of HK327M mutations, which are common in diffuse midline gliomas. And in Australia, we have the ACTION study that is recruiting and using this drug. And as always, patients have to meet the criteria to get into the trial, but you can explore more information about these studies or treatments with your clinicians. How about immunotherapy? Immunotherapy works by teaching the immune system to fight the cancer cells. So immunotherapy blocks the effect of the cancer cells on the immune system cells and thereby activates the immune system response. But although we have seen a lot of success in tumor types such as melanoma or lung cancer, it hasn't been that successful in gliomas. And the reason is gliomas are what we consider cold tumors. They lack the immune cells required to mount an immune response, and the environment is what we call immunosuppressive. So how do we turn cold tumors hot? Through using combination therapy before surgery. And the first publication I've put there is how three immunotherapy drugs were used to activate the immune microenvironment in glioblastoma. And the success of that case has led to the development of a new trial, the GIANT study, which is currently in setup, but it will add to the understanding of how to just awaken that immune environment in the tumor cells. How else can we turn cold tumors hot? Through CAR T-cell therapies. This is where T cells are removed from the patient, taken to the lab and engineered to be able to identify the surface molecules on the tumor cells. And this type of treatment has been quite successful in a lot of hematological cancers, but not so much in solid tumors. But there is a lot of work underway to try and find out how we can use this type of treatment in glioma. And these are just some of the studies that were presented at ASCO, an international oncology meeting earlier this year, which just shows that there is a lot of work happening in the background as we search for more and better treatments for glioma. These drugs are not yet in the clinic, but research is ongoing. And another way to change the immune microenvironment is through using vaccine trials. And this is a type of treatment where the tumor tissue is used to find antigens and neoantigens, and based on what they detect in the tumor tissue, they develop a personalized vaccine for that particular patient. And then these vaccines can be given either alone or with immunotherapy. The Brain Cancer Research Lab is another center that is leading in the brain cancer research space. Their recent work in low-grade glioma with an IDH inhibitor called safusidenib just highlights that there is the expertise and resource that makes it possible to carry out groundbreaking research. And they published their work on the brain pop trial in Nature Medicine, which is a prestigious medical journal, which just shows that there is a lot of work always happening, even though we may not know about it as we try to find better treatments for patients. Then the Australian Brain Cancer Registry collects clinical data and specimens to facilitate research. They identify and address any variations in clinical practice and outcomes. And they are also establishing standard guidelines and protocols in how to use tumor organoids, which are essentially tumor models, to just carry out more research as we try to find new drugs and better drugs as well. So I hope I have shown you how there is progress being made in glioma, and that you, together with your clinicians, researchers, and scientists, are contributing to this international effort. So thank you. And please do discuss clinical trial options with your clinicians when you meet with them. Thank you for listening.